So it's my pleasure to introduce our moderator of today's discussion, James Doyle. James is Senior Director, Commercial and Public Affairs with Stryker, and also a member of MTAA's Public Affairs Committee. And most recently, James was one of the leads of MTAA's COVID-19 supply working groups. And James played a key role in MTAA's leadership and our successful collaboration across industry and government to ensure that Australia had sufficient supplies of essential medical equipment and devices needed to meet the challenges of COVID-19. So James was one of a number of company representatives who were effectively seconded to MTAA, and he provided an enormous contribution to that very successful work. So thanks, James, and I'll hand over to you.
Thank you very much, Ian, and thank you for the very nice introduction. It was fantastic working so closely with MTAA during that time, and even having you as my boss for a short period in time as well. I
just taken you on speed dial, so it's taken a while.
I want to thank the panelists who we have here today. It's going to be a very interesting discussion and a very timely discussion as well. This webinar brings together leaders from across private, public health, as well as our surgeon community, as we look at the challenges that will be presented with the return of elective surgery. So a couple of key questions we're going to ask today are, first, how far has elective surgery returned to normal efforts or normal rates of effort from today? What are constraints in us getting to full capacity? We're going to look at risk management associated with the safe return of surgery as well. The role of the industry rep will come into the question as well. What the lasting impacts will be beyond COVID-19. And then finally, we're going to take some key points from the recently announced National Health Agreement to get an understanding of how that policy will impact us moving forward. So with that, I'd like to introduce our first of our panelists, and that is Alison Verhoeven. Alison is the Chief Executive of the Australian Healthcare and Hospitals Association, the independent peak membership body and advocate group for the Australian healthcare system. You have a national voice for universal, accessible, high-quality healthcare in Australia. So welcome, Alison. Delighted to see you on the call. Do you want to start off with a bit of an overview as to what you see as being the impacts of COVID-19 so far on hospitals?
Thank you very much, James, for that introduction, and also to Ian. And hello, welcome to all who've joined us to hear about elective surgery and the suspension. So as you all know, in March, the states and territories, together with the Commonwealth, took a decision to suspend non-urgent elective surgery. In the lead up to that decision, a number of states had actually brought forward some stage 2 and stage 3 procedures in anticipation of a suspension. But following March and the decision to suspend, pretty much all category 2 and category 3 procedures came to a halt. And that was the case during March and April. We saw a slight pickup during May, and then more recently the National Cabinet took a decision that elective surgery might resume. And the aim is to have a resumption to 75% by the end of June. What I thought I'd do is have a quick look around the states and territories and see how that's played out, because it has been a little bit different in every state and territory, notwithstanding this being a national decision. But also the impact that the decision to suspend elective surgery had on waiting lists in particular. So you'd be aware that the public hospital system provides about 40% of elective surgery in Australia. Research from the International COVID Surge Project, which was published in the British Journal of Surgery in mid-May, estimated that around 400,000 elective surgeries were cancelled in Australia due to COVID-19 during between February and May, and that included 25,000 cancer surgeries. The researchers estimated that it would take about 10 months to clear the backlog if elective surgery was increased to 110% of pre-pandemic capacity. And it would take about 5 months if that effort was increased to 120%, or about 3.5 months to clear the backlog if it was increased to 130%. But just keep in mind, most states and territories are aiming for an increase to 75% of capacity by the end of June. So there is going to be a substantial backlog. Each state and territory is dealing with it a little bit differently, and in some cases it's about injection of more funds. For example, in Queensland, where there's been several $100 million injected into the system to really address that waiting list. So that extra funding is supporting things like non-urgent surgery being undertaken outside of regular hours, but also in partnership with the private sector. And I think that's been a really key point. During this journey, the partnership between the public and the private sector has been really critical to ensure capacity in the system. In Queensland, they're actually saying that they have activity up to about 90% of normal activity already, but that is a bit maldistributed across the state, so it depends on the capacity and of each individual hospital, but also the availability of personal protective equipment. And the Director General of Queensland Health has said most recently it will probably take up to 12 months to clear the backlog, or longer if there's a second wave of COVID-19. In New South Wales, there's more than 90,000 people currently on the waiting list in public hospitals for elective surgery, and they're only aiming for a return to normal activity by the end of July. And to put that into context, there's about 235,000 elective procedures done every year in New South Wales. So to have 90,000 people on the waiting list is it's a huge pressure on those waiting lists. As in Queensland, that's unlikely to be evenly distributed across all hospitals. So some hospitals are going to do better than others. And each hospital is being tasked by the Minister to balance the need to maintain their COVID-19 preparedness and also to manage the surgical lists and to ensure that there's appropriate attention to priority. The New South Wales government has just kicked in this week $388 million to support the resumption of elective surgery, and they'll be doing that in partnership with the private sector. But that raises issues, including issues raised by the AMA in New South Wales about the income that doctors might earn if they're being required to provide more public services in private hospitals. The impact on income that they might normally have earned through their private practice is an issue. Very similar story in Western Australia. They're up to about 100% of their historical average as at 15th of June. And just this week, they conducted in Western Australia 3,500 elective procedures in public hospitals. In South Australia, one of the issues there has been managing the waiting list for people from the country, accessing procedures in metropolitan hospitals. And that's been a particular issue which the South Australian government has sought to address through a direction under the Healthcare Act, which aims to ensure that overdue procedures, including those from the country areas, are prioritised in metropolitan hospitals. The Minister Wade in South Australia has previously commented that the backlog will be addressed this month, but as I've not yet seen the data, I'm unsure that that actually is achievable. In the ACT, we've recommenced elective surgery, and I'll highlight here including dental surgery. So public dental surgery is one area of public hospital service which has been very impacted by the suspension of elective surgery. The ACT Minister this week said an important statement which I think sums up the risk management issues that are being experienced in the public sector. She said, while we would like to conduct even more elective surgeries, we need to do so to ensure we are doing so safely and we're preserving our personal protective equipment supplies. This is to ensure we can protect staff and patients should we experience another outbreak of COVID-19 in the ACT. The impact will be closely monitored and reviewed to ensure it doesn't compromise the territory's preparedness to meet demand for public hospital services from any increase in COVID-19 cases. So what we're seeing right across the public sector is essentially a risk management approach, anticipating, responding, mitigating, and then eventually moving to a scenario where residual risk will shape policies and procedures. I think there's some really interesting work being done in risk management. I'd just quickly like to mention a testing program that's been initiated by the National Elective Surgery Task Force at 14 public and private hospitals across Australia, including the Alpha and the Epworth, in Monash Medical Centre, Royal North Shore, Westmead, Prince of Wales Private. And in that program, about 3,000 people undergoing elective surgery will be tested for COVID-19 or antibodies that indicate they've previously had COVID-19 in the past 6 weeks. And this follows on from a study that was published in The Lancet in May, which found that 19% of patients with COVID-19 died within 30 days after having surgery, and more than 2/3 of those patients were diagnosed with coronavirus post-operatively. So the Australian task force that's implementing this program is an important body of work, and that work is the results of that work will go to the Australian Health Protection Principal Committee by July. More generally, I think longer term, we're likely to see protective masks, gloves and gowns remain standard practice, and particularly as clinicians and services remain really vigilant about a possible second wave of COVID-19. But I know my colleagues, Lynn and Annette, will talk a bit more about that, so I'll leave them to follow up on that. Just a last thing, James mentioned the National Health Reform Agreement and asked me to talk about what that might mean. So very quickly, it has a very strong focus on patient outcomes. There's provision in the National Health Reform Agreement for 2020 to 2025 to explore innovative funding models. And in particular, that'll be looking at addressing variation in the types of care that's provided across Australia, be looking to reduce low value care, but also gives authority to the Independent Hospital Pricing Authority to start trialling new models of care. And really importantly, I think, for the medical technology sector, Schedule C of that agreement highlights some new ways of undertaking health technology assessments in the public sector. This is really critical. You would all have experienced the variation across states and territories in the way health technology assessments are implemented. There is going to be a working group that's aiming to create a federated approach with a national framework for health technology assessments. There's some exemptions from funding caps for new therapies for 2 years in public hospitals. There's some requirements around timely decision making, which I know will make all of you happy. And there's also some requirements around improved transparency and information sharing. So I'd suggest to you, if you have an interest in it, have a look at Schedule C. It's a very large document, but Schedule C, clauses 7 to 16, are the key ones about health technology assessment. Thanks very much.
Alison, that was a fantastic overview of what's happening in the states and territories, so thank you for that. But I think some amazing insight as to the future as well in the post-COVID world. Consultant orthopaedic and trauma surgeon at Monash Children's Hospital, and a counsellor at the Royal Australian College of Surgeons. The first female to do so. As if this isn't enough, she currently holds RAC's external affairs portfolios in the Air Force. She holds the rank of group captain, and she's clinical director of surgery for perioperative services for the RAAF. That is quite the introduction. I don't know where you find time for any spare time, but thank you for being here with us today. We appreciate you taking the time to spend with us. I was hoping you could give us an overview from the AOA and
Thank you, James. I will just say my internet seems to be problematic, so if my sound is a problem, let me know. We might need to go to somebody else and come back to me.
Okay, I'll wait.
So I've been involved with the COVID response sort of at 3 levels, really. One, as a college counsellor, which has been minimal on my part, though the college has had a lot of response. I haven't been deeply involved with that. It's largely been through management and the president communicating out to the specialty societies. At the AOA, it's been quite different because of my role there in the presidential line. I've been involved with weekly meetings and a lot of communication going out to our members and online meetings, which have been quite revolutionary. We've been meeting just about every week, discussing the impacts on our surgery and trying to project forward and see what might be happening. I have to say, over the same time, we've been having very regular meetings in the early hours of the morning, for me anyway, with MTAA, trying to help predict where we're going. And then through my work in Victoria, I'm a little bit involved with the perioperative working group for the Department of Health in Victoria. But there are many working groups, so we really only see our little corner. At the present time, we're probably working around, it's pretty mythical, but I think we're working around 75% in our surgery, but there's no great way of knowing what level we're actually at. Some people are clearly doing a lot more than others. And I hope it's based on the patient need and the clinical priority, those that are getting access to theatre. It's expected that if all goes well, we'd be back to 100% by the end of July. That was the predictions. And then there's some limitations, and there are a few spanners thrown into the works. So the limitations really on the way through have been about allocated beds for elective surgery. There were a lot that were closed and became potentially COVID wards. There was limitation on our staff and not wanting to burn people out. We also had to have training time for staff about PPE and how to manage patients who were infected. And there were certainly limitations on PPE, which I'm really not sure have actually disappeared yet. And your group would probably be the ones to tell us whether there really is going to be a resupply issue, even extending out into July and August for us. But we have got through so far, and things are opening up, and we aren't burning through quite so much PPE as we were, because fortuitously we haven't had quite the tsunami of COVID-19 patients that we could have experienced in this country. Probably one of the great wins has been the introduction of telehealth for our consultations. It's been interesting to suddenly change from one week to the next, from no telehealth in our clinic to virtually all telehealth. It's really hard on initial consultations, particularly in orthopedics, to do an initial consult that way, but the follow-up appointments has been fantastic for people just needing a result or the result of an X-ray, and particularly the country patients. That's been an enormous step forward for them to be able to engage through telehealth. I think one of the difficulties, though, has been through the general practices and through the specialists that we've had less people coming in as new patients. So I'm sure there is a big backlog of people who haven't sought care in the last 3 months for particularly their orthopedic conditions, because they probably considered they were things that could wait, but also other specialties. And they're now starting to come through to our practices and through the GPs for referral. So I think there is going to be, whilst the pipeline narrowed there for a little while, I think there is going to be a big bulge out. We did have really big waiting lists already of people who were waiting for surgery before this happened. And so it may not have peaked a lot more over the last 3 months, but I think it's going to take off now. And I have to say personally, it's not representing either of my organisations, I'd really like to see that investment in public health go into public health. If we're going to be doing evening work and weekend work, I think it's an enormous opportunity to properly invest and allow people who need their public surgery to be done in public and have that well resourced. One of our concerns about upgrading the rate of surgery is in reference to the paper from the National Institute of Health Research from the UK, that Alison referenced in late May in the Lancet, because the death rate, if you did come in and you had an acute emergency and you were a man aged over 70, it was a very high death rate, I think approaching 50%. But even for very minor surgery, who with no symptoms at the time, I think, certainly for minor surgery, the death rate was still up near 16-17%. And that's higher than we would normally expect for our critically unwell patients having emergency surgery. So it really is significant. And if we do have an incidence in our community that we don't recognise, as that progresses, we are going to hit a problem with unplanned transmission through our community. So we really don't want that to occur. The medical reps coming into our theatres, we do need reps in theatres, and for some places that's continued uninterrupted because there are quite complex sets that both the surgeon and the perioperative nursing staff need help with, where there's a vast array of options for us to use. We do need that help. It was problematic because we didn't want to unnecessarily expose you to risk during the crisis, and let's hoping that's all easing up. So, and things are changing now. But I think it has also opened up the possibility that that support might be provided with video links into the theatre rather than having to physically be there. Because I think we've all found with less meetings to go to, we seem to gain a lot of hours in our time when we weren't travelling through traffic across town to be the same, and we can be supportive online. So what's coming? I think that it's a real opportunity to develop a new normal. I'd like to see that flexible work could be introduced into our hospitals. Just like schools, operating theatres lie vacant for many hours out of a 24-hour period, and this is a real opportunity to provide more flexible work for perioperative nurses, anaesthetists, surgeons, and perhaps have those theatres being utilised on a regular basis in the evening and weekends. I think for our patients, it's going to ultimately result in better surgical care because we've done a lot more with pre-op planning and screening. People having certainly much shorter hospital stays because they've had their rehab after surgery sorted out, ready to go rapidly get themselves out of the environment. Surgeons have really developed our communication skills, particularly online communications at all levels. It's been a great opportunity for networking within our professions as well. I'd really like to see more fractional appointments at the public hospitals. We've got a lot of young surgeons at the moment who can't get into public hospitals, and this might be the opportunity, rather than give other people overtime, but to have new employees who have fractional appointments at hospitals. So I think there's opportunities there. And I think the opportunities for online learning have just been fantastic. We've all had to shift very quickly. I hesitate to use the word pivot, but we've had to really change the way that we're working and doing our education. And for me, that's a big impact for how we're supporting our colleagues in the Pacific. And we used to do a lot of travelling out there to support their development of surgical capacity. And now we've just been forced to do that online. So it's a bit like teaching someone to drive. I think you have to actually let them take the wheel and stand back and give directions, and nothing better than having to do that online, probably similarly for our registrar. And ultimately, I think going forward, I think one of the other big opportunities for industry is to really look at reducing our surgical waste in operating theatres and reducing our carbon footprint. I just think it's not a time for us to really think about what effect we're having in all our packaging, particularly in our consumables that are single use, the effect they're having on the environment. And perhaps that comes particularly from my involvement with the Pacific as well. Those people are living climate change at the moment, and we are all concerned about our theatre waste. And perhaps I might leave it at that and take questions at the break. Thank you.
That was fantastic. Thank you very much. And I think the question around flexible working and changing for the future is a really interesting one. Finding more capacity within our system through flexible options. It sounds exceptionally interesting, so thank you for that. The final panellist that we have today, and I'll stay off video just as I understand there's a few connection issues for me, is Lynn Simpson. So Lynn Simpson is Group Procurement Manager for Ramsay Healthcare. Lynn joined Ramsay in 2015 from little company in Mary, Calvary, where she was National Procurement Manager from 2009 to 2015. She also procurement and supply chain function across all divisions of the company. Lynn has also held roles as CEO and Director of Nursing of Canada Bay Private Hospital, and procurement manager roles within Symbian Health as well. Lynn, it's fantastic to have you here. I know you're exceptionally busy right now, so I appreciate you being here. I was very keen, I'm sure everyone on the call is keen to understand how COVID-19 has impacted Ramsay. Really interested to see how you guys have weathered the last couple of months, and then maybe a bit of a view as to what the future looks like for Ramsay Healthcare as well.
Great. Yeah, thanks for the invite and the opportunity to come and talk about Ramsay and how we've weathered this storm. So while everyone I think has been at home and twiddling their thumbs, my team has been extremely busy trying to secure enough product for the surgeries that we were doing. So extremely busy last 12 weeks for us as a procurement department. And not seeming to get any better as we speak. From a Ramsay, from a private health perspective for us, with the announcements in March of the cessation of the Cat 3s and non-urgent Cat 2s, saw our business decline to about 25% of our capacity that we could do at the height of the crisis. As we work around the states, as we regroup and revamp the business, opening up, WA for us and Queensland are now back. They have the ability, there's no restrictions, they can go back up to 100%. The main restrictions there we have is product and ensuring that we have enough product and ensuring that we're providing a safe environment for not only our own staff, but the patients coming in as well. New South Wales, by the end of this month, we can go to 75% capacity, and Victoria, hopefully 100% by the end of July. Supply chain for us, and I make note of Annette's comment on the PPE, and I think that is still an issue. We are still seeing issues, not so much in PPE, but the actual quality of the PPE. That came in during the last 12 weeks, and also other products within surgery as well, such as surgical apparel, sort of gowns, masks, gloves as well, filters, anaesthetic circuits. A lot of things are seeming to be supply issues, especially for those coming out of China. There seems to be quite fractured, that supply chain. We're seeing that air freight is actually coming in quicker than sea freight, which is surprisingly, and also that availability of raw materials as well, and to how they're going into products and the actual lack of raw materials that are there. So for us, ramping up is going to take some time, I think, for us to go to full speed and to get back to where we were. With regards to industry reps, which I'm sure you're all wondering about what my thoughts are, well, not so much my thoughts, but Ramsay's thoughts and what we're doing with reps. We're still not allowing reps into the operating theatre or into the hospitals at the moment. I think the way we do have reps engaging in hospitals will change, and it'll be extremely different in the future. We've discussed some digital strategies about how reps can support our surgeons and our nursing staff in both education and new products, and how that can look from a digital platform. I'm not sure when reps will be allowed back in. We are putting provisions in our hospitals for visitors to come in. I'm assuming that the next step would be reps. The issue with operating theatres and with representatives being in the theatres is that they're small. We're still trying to work out how, if we get back to full capacity, how do we maintain social distancing within our tea rooms of our operating theatres, and how do we actually control supply of PPE. We saw a lot with our PPE that we actually used the wrong amounts of PPE inappropriately for situations going through. So how do we address that as well, which we've worked over the last 12 weeks, and especially with reps coming in and using that precious commodity as well. So for reps coming in, I'm not sure what that looks like or when that'll be. The lasting effects I see from COVID, and I'll talk about our industries overseas and what they've implemented. It hasn't been mandated in Australia as yet, but the UK have put in an operating room between cases. They have to let the room sit for 30 minutes before any personnel can go in there. Once the 30 minutes elapses, you're able to go in, the cleaning staff are going in and cleaning. This is definitely going to push out our time between cases and the amount of cases that we can do per list. So I think for me, the lasting effects of COVID, I don't think we really know yet. And we haven't, I think, thought about how it's all going to work. I think there's lots of issues. And how do we reset that new normal with cleaning, with social distancing, and how that interacts within the hospitals? I'm not too sure, but hopefully sooner rather than later, we will get back to full steam. So I think, yeah. Thanks, James.
Lynn, thank you very much for that, for the overview. I think interesting perspective that Ramsay has, being a global company and seeing some of those other countries are managing the response to this pandemic, and also the changes that are happening as well. I think the question, and we do have a question here around the role of the rep in theatre, but also the role of the rep with the medical device company in theatre and in training, from Roberto Alwazada, sorry. So I might just pose that question across to Annette as well. In terms of the role of the rep moving forward, Annette, where do you see that in terms of supporting procedures, and then also in the case of the safe and effective use of products and mentoring and training as well?
Well, I could speak from the surgeon's perspective. It's possible that we could have better education and be much more aware of the product before we start the case, to have had a discussion with the rep online beforehand would be better than having to rely on someone being there beside us. The perioperative nurses often need help. And look, having actually been in a similar situation, I broke my arm and then had to tell a general surgeon how to put an X-fix on a leg. I'm very familiar with just picking up what I need, and I know where things are, and I know what it should look like. But actually having to use my words and direct people to find the right instrument and the right piece is actually very challenging initially. And I can imagine if we were trying to do that digitally, it would take some work trying to work out how we supported people remotely. Lynn may have some experience with that from Ramsay. It sounds like you've been doing that more than some other companies, but I think it's possible. It's just a different way of working, and I think the time efficiencies would be enormous.
Thank you, Annette. I do agree, and even from a Striker perspective, finding new ways to connect with customers has been something that we've been focused on at this time. So totally agree. There's lots to be leveraged from these platforms like Zoom and FaceTime in terms of providing support. The next question I'm going to move to is in relation to the partnership agreement. When this is probably more focused towards yourself, the partnership agreements with government limiting the ability to use beds at your disposal. Is this having an impact on Ramsay, and how long do you foresee this happening for?
So over the past 12 weeks, Ramsay and all of the state governments have engaged in agreements to work together and share product, share equipment, and share beds. As everyone's ramping up and we're changing, some of those agreements have a pause function within them. So we can actually pause those agreements and reactivate should a second wave come. We're talking with the governments about that, but we'll work. Ramsay is very keen and always has been to work well and closely with the government and the state departments, the New South Wales Health and Queensland Health and everywhere. So is it impacting us from a bed number at the moment? No, not really. We're not up to 100% capacity. Most of our hospitals are around probably the 70 to about 80% capacity at the moment, depending upon which state they're in.
Perfect, Lynn, thank you for that. I think a lot of people looking to predict what the future will look like in terms of capacity as we move forward. I might just change tacks a little bit now and move to the National Health Reform Agreement. Alison obviously mentioned that within her overview of the environment as we move forward, and just the implications of the National Health Reform Agreement in the provision of elective surgery to privately insured patients in public hospitals. It's obviously been a contentious issue over time. But Alison, any thoughts from AHHU yourself on that particular topic?
Yeah, thanks, James. Yes, there is a schedule in the health reform agreement that was signed a couple of weeks ago around the provision of elective surgery to privately insured patients. So the right of states to offer that service through public hospitals is retained, but there are, I think, some really clearly articulated arrangements around how that should occur. So stricter arrangements around the recruitment of private patients in a public hospital, around the management of waiting lists and so forth. So in fact, they're not arrangements that didn't exist in the past, but they're being made really explicit in the agreement. So, there's a requirement for states and territories to really explicitly follow those arrangements and to report on them, and they can be held to account for those. We at AHHA, we are very supportive of that. We think that, those arrangements should be enforced and they should be managed strictly, but we also think that the right of public hospitals to provide private services should be retained. That's important for employment and recruitment of doctors, particularly in regional areas. It's really important in particular areas of health practice, for example, in paediatrics, where much of the work is done in the public sector. In areas we're requiring intensive care, where much of the resourcing is in the public sector. So we think it's really important, but it's equally important to have those safeguards in place to protect the rights of all patients to access care on the basis of need.
Thank you very much, Alison. We've had a question, I suppose, just for a bit more clarity around the cleaning requirements that we're seeing in between cases, and some of the requirements on PPE for surgeons as well. I wondered, Lynn and Annette, whether you could maybe expand upon maybe some of the changes that we're seeing in terms of PPE requirements, what's changed from before to now, and then also what's happened or what's changed in relation to the cleaning requirements that could cause delays, and what kind of, if you think there's a material impact to how many procedures can be completed in a particular list as a result of that.
You want to speak to that, Lynn, or you can
I don't mind.
speak to some of it? I can do some of the practical side.
From a Ramsay perspective, what we've seen mandated, like I said, mandated in the UK, is a requirement for an operating theatre to sit idle for 30 minutes prior to any cleaning post a procedure being done, before the next procedure and the next patient can come in. Ultimately, that is going to push out procedures. It's going to push out the number of procedures that can be completed on a list. We don't have that at the moment, but we are routinely cleaning, and we're doing a lot more and more, I guess, a greater depth of cleaning between patients now and protections. I do think that will decrease the amount of cases we can do per list. I think also just the bringing in patients as well, and the anaesthetic bays. We'll now have to socially distance patients in those anaesthetic bays. Patients will stay, I think, down on the wards and then be brought up. So I do think there'll be delays between cases in the operating theatre.
So some of the practicalities have been around is it a confirmed COVID case, a suspected COVID case, or a non-COVID case? So at the start of this period, we were treating everyone as could potentially have COVID because we had no idea what the community incidence of infection was. And we think we've got a better idea now, and it's very low. But at the start, where we've got to is if it's COVID or suspected COVID because of symptoms, but is therefore needing emergency surgery, we do have a period, particularly with either the intubation, which is aerosol generating procedure, or if the actual procedure is something to do with the upper airway or the lungs, particularly the airway generating, then there must be a period afterwards in which the theatre is clean before it could be used and considered sterile clean again, not really sterile. But for those who don't have COVID and not suspected of COVID, we're just back to the normal handling of our operating theatres. And that study that's happening, looking at swabbing our elective cases, will very quickly help us work that out. If we get almost 0 out of the 3,000 people turning up to have COVID, that'll be very reassuring. And we should know very quickly because of the time forgets the results. But if we end up with, even 1% of people who have already been screened as not having COVID based on their symptoms, because everyone is screened now coming in, the elective surgery patients all have questions about symptoms and fevers and things. If they're all screened and it's thought to be negative, but when we turn up some positives, even up to 1%, that will really shut theatres down again because we cannot afford to have that sort of death rate from even minor surgery.
Thank you. Thank you both for those answers. I just want to take this opportunity just to remind everyone at the bottom of the screen there is a Q&A button. If you guys would like to ask any questions of this panel, please type in your question on there if you can. You can choose to leave your name or not to leave your name. It can be anonymous if you wish or otherwise. Thank you to Paul Doyle for a couple of those questions already. I did want to combine a couple of questions that we've received on here to the panel and maybe get a bit of a view from them around capacity within hospitals and potentially questions around triggers of when we can increase capacities. This, Alison, might be different by state, so it may be good to get your view on a state-by-state basis within the public as to the capacity levels and when we can get back to 100%. But then more broadly, it'd be good to understand whether we can actually get back to 100% or beyond 100%. As Alison mentioned, we do have somewhere in the region, but from the numbers we had of almost 400,000 surgeries that have been pushed back and potentially greater than 10 months worth of addition to the waiting lists that have occurred. So I may start with yourself, Alison. In terms of increasing capacity, what are the best ways forward in your view?
Yes, thanks very much, James. Look, I think as regards the state-based triggers, I mean, each state is looking at what the Australian Health Protection Principal Committee and the National Cabinet are advising, but then they're also using their chief health officers and the resourcing within their own system to make decisions based on the situation in that state and territory. And clearly, if you look at COVID-19 numbers at the moment, you would see, for example, in Victoria and to a slightly lesser extent in New South Wales, an exercise of caution is going to be required because there are numbers still there. And as Annette said, with this study that's underway at the moment, if there appears to be through that study greater community transmission than we understand it to be by looking at the numbers more broadly, behaviours are going to change and decision making is going to change. And I think each state has been very clear that they're going to make decisions based on what's the situation in their state and what is appropriate for their state. And we think that's a suitable thing to do. Yeah. And the flip side of that is each state is also going to make decisions about the funding they have available to inject into the system, and whatever part of the electoral cycle they're in as well will, ultimately shape some of that too, quite cynically. But at the end of the day, some of the addressing of the backlog, including the ramping up to, say, for example, 120% or 130% to address backlog, that will require funds, whether it's, you know, funding to keep theatres operating after hours, whether it's contracting with private hospitals, whether it's using theatres in different ways. All of those strategies ultimately come back to resourcing. And so, again, that will be a state-by-state decision.
Alison, really good. I think you're right. We're seeing that play out in terms of each state's approach right now to capacity as well. Just keen to get views from the private sector on this as well. So Lynn, in terms of reaching beyond 100%, how do you see the private sector stepping in to do that to take care of this backlog? Lynn, you're on mute.
Sorry. Look, I think that Ramsay will, and with any private operator, will be up for increasing as much as we can and putting through the throughput. For us, the key indicators for how we ramp up and to what level we ramp up will definitely be around supply and products, and whether or not we have the right amount of PPE and additional products as well. We're still running a daily PPE report that my team's running. That's fed up to our ops exec. We meet at 10:30 every morning and run through how much inventory we have, how much was used the day before, what's our run rate for our last 7 days. So if we have enough PPE and enough surgical gowns and other equipment, we'll ramp up as fast as the states let us.
Good to hear, Lynn. And then from a surgeon perspective, Annette, in terms of working down these lists, obviously you mentioned flexible working, but any thoughts on how we reduce these longer waiting lists?
Well, it's to increase the amount of surgery that we're doing in public would mean we were already pretty much at capacity with using them in hours. So I think a lot of the incentive funding that Queensland and New South Wales has been in the media early in the week is about evening and weekend lists. The difficulty for me around that is there's already surgeons who are working very hard and not getting much time off. I just see it as a way of burning people out, because it's going to be a long tail that takes us to clear what was pre-existing before this, let alone the build-up around 3 months of not operating. So I'd think much better than trying to burn out people who are already appointed. It would be better not paying people overtime, but getting new staff to help man evening and weekend shifts. I know that won't be an initial response. It'll be people who are already there, but I'm quite sure there'll be perioperative nurses who could, by choice, work evenings and weekend, and similarly for some surgeons and anaesthetists.
Thank you, Annette. I'm going to consolidate a couple of questions here from Juliet and Brian that came in on the Q&A, and they relate to more questions around the role of the medical rep. The first of the questions from Juliet was how we best in the medium term support clinicians and organisations at this time as they look to ramp back up. And the second was in relation to probably the other side of that, the risk of not having that technical expertise available to support, especially in complex surgeries. So I might just take maybe some views. We've touched on a couple of views already, but in terms of the best ways to move forward for the medium term, Annette, I might start with yourself as we left off.
I'm speculating here, but I would think it would be around when somebody's ordering equipment and asking for tech support. Perhaps there could be some focused questions about what the surgeons actually needing the support for. Is it the nursing staff who need the support? And whether some of that could be provided through some education before the case, or whether that's something that's emailed to them or some online discussion beforehand and going through things, because it's certainly dangerous to try and do an operation without support if you need it. I've certainly been stuck in the middle of operations and had difficulty getting support, and then you have to make it up as you go. It's certainly not an optimal outcome for your patients, to even just time-wise, even if everything goes well.
Thank you, Annette. When you've obviously spent a lot of time around theatre yourself, in terms of you seeing the role of the rep moving forward, how do you see them best supporting in the next medium term?
Look, I think there'll always be a requirement for company reps to support not only the nursing staff but the medical staff as well. How can we do it differently, and how do they have to be in the operating theatre? I don't think they do. I think there's a multitude of ways we can do it, and I think that being thrown into the deep end during the pandemic, I know that I worked in an office and I sat in a building 5 days a week with 200 other people. You know, over a 24-hour period, those 200 people went home. Our business is still run. We've still done our jobs and we've worked remotely. We've connected in with the people and everything that we've needed to do. I think there's probably an avenue that needs to be looked at and reviewed as to how can we do that, and can that happen from a medical rep supporting not only physicians but clinicians as well in the operating theatre without actually physically being there.
Thank you very much, Lynn. There's a question here that potentially could be a prickly one for us to finish off with, but I think I may as well throw it out there anyway. And it relates to what we see happening with public elective surgery being done in private and the impact on private health insurance as well. A few people are obviously quite interested as to what's going to happen to the product and private health insurance with so much focus on the public waiting list being worked through. So I might start with Alison on this one and maybe get that view. Alison, not to put you on the hot seat, but maybe you can give us your view at this stage.
Sure. Look, I mean, I think the reality is in Australia we have a mixed public-private system, both in terms of service providers, but also in terms of funding. That's a reality in which we work, and that will continue beyond this current experience. But ensuring that value is sort of central to the proposition about how we all work, I think is also going to be really critical. So it's going to be critical for all parts of the system, including public hospital, including private hospitals, and including private health insurers and governments as funders, to think about value. And perhaps this is an opportunity for us all to actually step back a little bit and think about value for patients, because frankly, that's why we're all here. We're not here for any other reason. And so perhaps, you know, shifting that mindset a little bit and really starting to focus on high value care and what that means in the system, I think is going to be really critical. Now, I think some of the things that Lynn and Annette and I've talked about today actually point towards that. We're all thinking in these same ways. How can we be more flexible? How can we be more agile? How can we manage risk? These are all key issues in our society, but also in the way health services operate. And until we really focus on those issues, you know, that's what will drive what the system looks like in the future, in my view. There'll be a challenge for private health insurers.
Very good answer, Alison. Thank you for that. I might jump across to Lynn. Any thoughts from yourself, Lynn, on the future?
Oh, look, I think the whole, it'll be a completely new norm. I think it's something we don't know what it's going to look like coming out of here, out of the pandemic. You know, you look at it, we've had the lowest infection rates of influenza for the last 5 years this year. Like it's because we've all been social distancing, because we've all been at home. I don't know what it's going to look like. I think there's a place in Australia for both the public and the private system. I've worked in both. And I think that, yeah, I think they'll both survive. It'll just be how we come out of this, and hopefully we come out working more collaboratively together.
Absolutely. I think one of the envies of the world is our health system.
Yeah.
Here in Australia, and I think protecting that should be something that's important for all of us on this call. I agree. Annette, any final thoughts on the impact of private health insurance from yourself?
Well, I would hope that it's the fall off doesn't continue, because the bulk of orthopaedic work in this country is done in private, but that probably means there's a lot of uninsured people who are actually not getting the surgery that they would benefit from it through a public system. So I'm very much also in support of investing in public health.
Thank you, Annette. I want to take this opportunity just to thank all three of you for being fantastic panelists. All the prep work for today as well, in terms of understanding the issues that you've done, has been fantastic. You seem exceptionally well informed and have given this audience a great insight as to what we can expect from a surgeon community, private hospitals, and also the public health system as well. So Lynn, Alison, Annette, thank you very much for being fantastic panelists. I will now pass back to Ian Burgess for some closing remarks. Thank you all.
Thanks, James.
Thank you.
Great, thanks, James. Lorraine, you need to turn my video on, please.
Need MedTech support.
So we're right on time. Very well moderated there, James. Thank you. And thanks again to our panelists, Alison, Annette, and Lynn, and also James. A great discussion throughout, and particularly those final closing points, focusing on value for patients. You know, the discussion around moving towards a value-based healthcare system. Lynn working more collaboratively together, and Annette in terms of investing in public. You know, what great points to be finishing off that discussion on. I get the sense we probably could have gone longer. We do have some unanswered questions, so if it's okay to our panelists, we might forward unanswered ones through to you, and we can respond to those afterwards, if that's okay.
Yes, indeed.
And as I mentioned at the start, we have recorded this session. We'll be providing that to our members at a later stage, to all members to access. So perhaps it could have gone longer, or perhaps we run a follow-up session in say 4 weeks' time to see what's progressed and if the challenges have been addressed sufficiently. But thank you again to our panelists and James. Thank you to everyone who joined, and keep an eye out for our next webinar. And if we our panelists are willing to, perhaps we might come back to a follow-up session. So thanks everyone, thanks for joining, and we'll speak again soon. Thank you.
Thanks very much.
Thank you.
Thank you.
Thank you.